Hello, and welcome to the Code Stroke Pathway for Bedside Nurses. It is recommended that you watch this presentation with sound. However, closed captions are available by watching the YouTube version of this presentation. Pressing the CC button on the YouTube video will toggle closed captions for the video. Many of the stroke treatments are time dependent, and every minute that goes by, a stroke victim loses more and more brain cells. The purpose of a code stroke process is to expedite the assessments and testing so that if the patient is eligible for treatment, it can be performed quickly, which reduces the brain cells lost and increases their odds of recovery. In this video, we will be going over how to identify if a patient may be having an acute stroke and what to expect for your role in the in-house code stroke process. Signs of stroke typically occur suddenly, although progressive increase in symptoms over time are seen with some patients, making identification difficult. In the community, the acronym FAST is used to help educate lay people to identify common signs of stroke and seek timely treatment. Some of the most commonly recognized signs of stroke include unilateral facial droop, paralysis or numbness, unilateral arm or leg weakness or numbness, and speech difficulties including slurred speech, loss of speech, word-finding problems, and disorganized, nonsensical speech. Another possible symptom seen with strokes is visual loss in one or more quadrants of the patient's vision. Symptoms typically only affect one side of the body, although both sides might be affected if the patient has bilateral infarcts, again making identification difficult. Less commonly identified signs of stroke include double vision with vertigo or loss of balance and incoordination, which are signs of a posterior circulation stroke. A classical sign of subarachnoid hemorrhage is a sudden onset severe headache that is often described as the worst headache of my life. The sign is referred to as a thunderclap headache. A sudden onset decreased level of consciousness is often seen with intracranial hemorrhages, although it can also be seen in large ischemic strokes. Time last known well is one of the most important pieces of history for stroke patients, as it is crucial for determining if patients will be eligible for time-sensitive acute stroke treatments. Unfortunately, it is also one of the hardest pieces of information to accurately determine. Last known well is the last time the patient was known to be at their baseline state of health. When obtaining history, it is often confused with onset, when symptoms began, and discovery time, when the patient was found with symptoms. This confusion often leads family or emergency responders to mistakenly report time of symptom discovery as the last known well. The only time stroke onset and discovery are the same as last known well is if the stroke occurred in the presence of someone where the patient is able to state the time it began. As nurses are often the first person to assess a patient with stroke symptoms, they can play a vital role in helping establish a last known well. When taking history from a family, patients, and other care team members, it's helpful to ask clarifying questions to ensure an accurate time. Examples include asking when was the time you last saw them at their baseline, when symptoms started, was the start of symptoms witnessed, or did the patient already have symptoms when they were found? Did they have symptoms before this episode, or did they wake up like this? If patients have episodes of symptoms that come and go, the clock resets each time their symptoms go away. In these situations, clarify that their symptoms did resolve completely, then use the time of the most recent episode of symptoms for the last known well. When reporting the last known well to others, be as precise as possible and avoid using terms such as 2 hours ago. With the recent advances in stroke care and the 2018 AHA guidelines, there is now acute endovascular treatment available for eligible patients with ischemic stroke up to 24 hours of their last known well. This has led to changes in how we evaluate for and determine if patients will be activated as a code stroke. The in-house stroke pathway was changed from bedside nurses calling a code stroke directly when they identified stroke signs in a patient to calling rapid response for a code stroke evaluation first. This allows for the rapid evaluation by a house supervisor or RRT nurse to evaluate the patient, perform a LAM screen, and determine if a code stroke needs to be activated. As a bedside nurse, if you identify a patient with new stroke symptoms and determine their last known well was within the last 24 hours, you should call RRT immediately for a code stroke evaluation. Don't forget to inform your charge nurse as well, as they will be involved in helping with this process. In the following slides, we will go over what to expect from this point in the code stroke pathway, including your role and responsibilities. At this point, you have called RRT for an eval and are awaiting their arrival. While waiting, perform any emergent nursing interventions that are needed based on the patient's condition. This includes things such as placing oxygen or performing suctioning. Other items to perform while waiting are bringing the crash cart, WOW, and the main paper chart to the room. The computer should be logged into the patient's record for review and if orders need to be placed. You will need to perform a bedside glucose, as glucose variations are a common reason for stroke mimics. If you are certified, you can perform an NIHSS and dysphagia screen. The house supervisor or RRT can perform this if you are not trained in these assessments. Although not always done this early in the process, you will need to inform the primary physician and the family of the patient's changing condition. When RRT arrives, they will perform their assessment and determine if a code stroke needs to be activated. If it is determined the patient meets code stroke parameters, it will be paged overhead by calling 3333, like other hospital codes. This will bring the ED physician to the bedside. The RRT or house supervisor will also contact the MICN in the ED to have the code paged through our mass communication system, which alerts other members of the code stroke team, such as the neurologist. When the ED physician arrives, their role is to evaluate the patient and determine if code stroke orders should be placed, if the patient may be a candidate for acute stroke treatment, perform any urgent procedures, and communicate their findings to the on-call neurologist. Our ED physicians see and treat acute stroke patients on a daily basis. They are extremely proficient at distinguishing stroke presentations from mimics and have additional background in applying higher-level clinical practice guideline recommendations to making patient care decisions. During this process, be prepared to answer questions about the patient's history and their current stay. Common things asked are the last known well time, what symptoms you noticed and when, what their condition was prior to the event, and their baseline prior to hospitalization if known. They will want to know what they are here for, any procedures done or pending, and what their medications are. This history can be helpful in determining if it is a stroke or other condition and if the patient may qualify for acute stroke treatments. If the physician agrees that this is a potential acute stroke, the code stroke orders will be placed in the EHR. This can be done either directly by the physician or via a VORB. If you are taking the VORB, make sure to clarify if they want a CTA in addition to the CT or just the CT for stroke. Also clarify if they want a second set of labs drawn or if the patient's previous labs are okay. If the physician feels the patient is not having an acute stroke or is not a code stroke candidate for other reasons, the code stroke orders will not be placed and the code stroke will be deactivated. Communication is key during this phase of the process to ensure all members of the team are on the same page regarding last known well, key history, and whether a code stroke is being activated. Once a decision for code stroke activation has been made, priority should be given to obtaining the initial CT as soon as possible. The patient will need to be accompanied by an RN on the monitor during this process. It's good to prepare for a stat transfer to CT as early in the process as possible by informing transport, placing the patient on a portable monitor, and getting an O2 tank if needed. Delays in CT should be avoided, and it's possible you may need to transport the patient down to CT if transport is not available timely. For patients that have a CTA ordered, if they do not have a 20 gauge in the AC, bring an IV start supplies to CT with you so it can be placed in between the non-contrast CT and the CTA. After the initial imaging is obtained, they can be brought back to their room, and any pending initial testing and assessments like the NHSS and lab work can be completed at that time. They should be in a monitored bed whenever possible, again due to the risk of decompensation. While the testing is being completed, the decision will be made whether to give TPA, if they qualify for endovascular treatment, or if they need transfer to a tertiary center for other reasons. The ED physician will likely have handed off care to the neurologist and attending at this point, so these physicians may need to be contacted if needed to clarify the plan of care. At the end of the initial code stroke workup, the patient may be transferred to another stroke center, or to one of our stroke units, 5-tower, PCU, or ICU, depending on the level of care they need. If the patient was not a code stroke candidate or was deactivated by the ED physician, the patient will typically remain on their current unit unless a change in level of care is ordered by the primary MD. The stroke tracker and TPA inclusion and exclusion form are available on the crash cart and are used by the stroke team to document key metrics. These documentation tools are in the process of being built into Cerner into the Power Form system. Once this documentation goes live in Cerner, the paper forms will be used for downtimes only. The code stroke order form is available in Cerner and is called Code Stroke Protocol. Please note that the imaging orders and labs are not pre-checked on this form, as the specific ones ordered vary between patients. If you are the one taking the VORB, make sure to clarify which ones will be ordered. If you have questions about this policy or presentation, contact the stroke office at 949-5854.